All right, so I'm starting recording. Let's just take a look together at what we have left to do. I'll share my screen and we'll look at it that way. That way we can see it all at one time. Go to this course. Okay, back to here, and I'll share it with you guys. All right, so you've got the 262 page, and we go to just content, and you've got the lesson plan that's due on the 14th. It's at the bottom of the content page. It's going to be the most, you'll actually have to do a little bit of research and stuff on this one. Just pick one of these guys up here, or if you have something else that's interesting, that's a special population type group, and you want to run it by me, just send me an email. I'll let you know if it works. Most likely I will say yes, especially if it's something that that directly interests you, so we'll look at that for sure. You've also got the reflection paper, which I've got the due date as the 7th of November. If you want to go ahead, pretty soon and just knock this out, go ahead. This is just a commentary on a follow-up / commentary on the other paper, the leisure experience paper. Did you stick with what you planned to do? How did it go? Were you successful? What sort of things got in your way of sticking with it? Things like that. It's not going to take any research. It's just you telling me how that went and whether it helped you guys out. One person has already turned that in. I put it late in this semester where you'd have time for, to see whether you stuck with it or not. I didn't want to have the awareness paper and then have you do it for 2 weeks and say, yeah, I stuck with it for 2 weeks. So I tried to put it later in the semester. So you've got that's due on the 7th, but you can do that basically at any time now if you guys want to. Then you've got the lesson plan that we have here. And we just took test 3, correct? Haven't we already done 3 tests? So we just have the final left other than that. And it's going to be basically comprehensive. It's not going to be really hard. It's going to be along the same frame of what you've been doing. If you've paid attention, you've been here and done well on the other tests, you'll do well on it also. And plus you still have all your materials to work with on the final too. So no worries on that. So basically reflection paper, lesson plan, and the final, and we'll talk about that between now and then. So I'm going to stop share and go to the PowerPoint, and we'll jump back in to where we are. You feel better about what we have now? We good? Okay, so I think this is where we left off last time. We were talking about exercise and how we can provide that through recreation therapy. And obviously there's different types and components of exercise. We know that there's a cardiovascular component, a strength component. Flexibility is also a type of exercise / fitness. Does anyone know what the conversation rule means in relation to exercise? Anybody ever heard of that? It has to do with how hard someone is working. With most of our patients, unless you're actually trying to really put a heavy workload on a particular client, then we want to go by this conversation rule. And what that means is while they're doing cardiovascular exercise or training, it should not be at a level where they can't carry on a conversation with us. To tell us if something's wrong or if they're feeling funny or anything like that. It doesn't mean that they might not be panting a little bit, while they're doing it, but they need to be able to talk and conversate with us like that. Just carry on a normal conversation. But these three main in the dark font here on this slide are the three most targeted components when we're talking about exercise. And what we can do in recreation therapy, it says here alternative methods of exercising. We can use so many different things as exercise. I mean, personally, I don't mind zoning out and getting on an elliptical machine or a treadmill or something like that. Some people cannot stand that, and it would be much better for them to go for an outdoor walk. You're still getting exercise, you're still getting cardio, but it's an alternative method. We talked about how some of our patients are going to have balance issues, things like that. Obviously, a better alternative rather than treadmill or even walking outside on uneven terrain might be a bicycle, a bike. A stationary bike would be a good alternative method to use with them as far as cardiovascular exercise. As far as strength training, we just need to remember that proper breathing is important. We know about exhaling and inhaling appropriately during workouts. You don't want to have them, if you do have someone who's doing some sort of lifting, weight training sort of thing, then, which that's not our main role. We're not generally as recreation therapists, just in a weight room having people lift weights for the most part. Sometimes we may do that to mix things up or whatever, but we just want to make sure that they're doing things properly, while they're in there and not being dangerous with the way that they're doing it. Breath holding during strength exercising is a bad thing. It's called the Valsalva maneuver. It happens a lot when people are trying to do like max repetitions. You instead of breathing properly, it's like holding their breath, turning red. That's not a good thing. It can raise blood pressure. It's just overall not a good thing to have. And we don't usually push our clients to that extreme either. So with strength, we can work on both strength to try to improve function. If we're talking about people who have debilitating issues, multiple sclerosis, Parkinson's, things that are going to show signs of deterioration for those people, we may want to try to work on strength to keep it where it is. We're not necessarily trying to bulk them up and turn them into Mr. Olympia, but we're trying to keep them from losing function for those daily activities. So, we work on strength for those reasons. Muscular endurance, we work on endurance where they can also continue to do the things that they like to do. We don't want them to be worn out from going up one flight of stairs, if that's not the way that it's always been for them. We want to keep that endurance up where they can still function and have a fulfilling life like they normally have, had in the past. Flexibility, when we're working with that, it says here we want to make sure that it's never painful. If we're working with them and they're doing flexibility, training, stretching, for me, I guess I would just have to sit this one out because stretching in any form or fashion hurts to me. I hate stretching. I do not like it. So I could not participate in your recreation therapy if it was supposed to not be painful to do work on flexibility. A lot of times it's not necessary because some of the clients we work with, if you're working with developmental disabilities, maybe patients with Down syndrome, they already have hypotonia. Cerebral palsy also has this at times, and that's where you're talking about low muscle tone. We talk about situations where clients have spasticity, where their muscles are really, really tight. We want to try to loosen that a bit if we can. If they are already at a low muscle tone and we're trying to stretch them or have them stretch, we're probably going to further loosen their joints and possibly cause damage. So we don't want to do that for sure. Something else that we have to think about in recreation therapy when we're talking about exercise and wellness for our patients is accessibility. That's a big thing for our populations, a lot of the populations. And some of the things we need to realize is that some of the machines aren't accessible for people in certain conditions. If you're in a wheelchair, are you able to use all the machines? Absolutely not. A lot of times the components of a machine can be adapted. You just want to assess whether or not your client is able to do an activity and receive benefit from it. So some things that we've seen through working with recreation therapy patients is there's alternatives to these machines. If they're not able to be adapted and they're not accessible to our patients, then we can use other things like stretch bands, free weights, ergometers, which is either like a bike or one that you can use with your hands. It also is the same way. It's just like a hand bike, basically. Some alternative activities to just going to a weight room or a physical fitness facility. So we can do things like aquatics, gardening, just basic walking, seated aerobics. That's really good for clients with balance problems, issues with stability. That's a really good choice. We used to do that with my older patients when I was working for the park commission here in town. We had a seated aerobics class, and it was one of our most popular classes that we had. Tai Chi is something else that can be done, which is very similar to yoga and other martial arts type training, where you are working on stretching, working on balance, flexibility, proper breathing. You're doing a lot of different things, and you can do it anywhere, basically. That's the good thing about a lot of these things. Aquatics being the one that is not so much the case. The rest of these things you could do at almost any facility you would work at. Gardening, you could probably find a place to work on a little garden with your clients. Give them a sense of accomplishment by actually growing something, maybe even be able to eat it at the end. There's something that is, makes people feel good about seeing something from start to finish and you were there for the whole process. So gardening, you can always walk anywhere. Seated aerobics, you could do that indoors, outdoors. The same with yoga, Tai Chi. I mean, they have yoga in the Grove here at Ole Miss sometimes. So those things, you don't even need a facility or specific place to be able to do a lot of these things that we can help our clients with as far as their wellness. So now we're going to get into some specific recommendations for some of the groups that we've talked about. And the first one is spinal cord injury. We've talked about how you can either have a partial or complete injury when you're talking about a spinal injury / impairment of the spinal cord. You're going to have loss of sensation. You're going to have change in motor function from this. So obviously that's going to affect what they're going to be able to do with us and how we want to work with them. So just a little stat here. Of people who at the time when I took these notes down, there were, out of the people who had spinal cord injuries that we were working with, 47% were cases of paraplegia, which is basically the lower limbs are affected, upper limbs were not. And 53% are quadriplegia. So pretty close to half and half on that. Some considerations that we have to think about during exercise with this group: spasticity. That's where we're talking about muscles a lot of times. Now, this is just a reflex of the body, not anything that they are making themselves do by any means. The spasticity, muscles just tighten up. And some of that can come from disuse. You know, the body's just trying to use something that your arms may draw up if they're not being controlled and used and stretched out. So that can be something that comes into play. There's also autonomic dysreflexia. That's extreme hypertension, very, very high blood pressure. That's seen in about 60% of people who have a spinal cord injury at the level of T6, which is up here in the kind of the upper back. T6 or higher. It's just an autonomic response. It happens, the body tells it blood pressure to go high because of where the damage has happened. So in that situation, we're talking about high blood pressure. Then we have cases of orthostatic hypotension. So again, you hear hyper, that's going to tell you high. If you hear hypo, that's going to tell you low. So always try to think about those like prefixes on your words, and you can kind of figure things out by that a lot of times. So hypotension, we're talking about a drop in blood pressure, and it's basically, in this case, it's due to pooling of muscles in the paralyzed areas of the body. You know, the areas are paralyzed, and blood just tends to pool in those areas because there's not any movement going on to help circulation occur properly. Another thing we see in this group is impaired thermoregulation. They have a hard time controlling their body temperature both directions. They can get too hot pretty easy, and they can get too cool pretty easy. So it's just something to know when we're talking about working with them in an exercise. You know, we may not want to get them out in super, super hot weather. We may not want to get them out in super, super cold weather. Loss of bladder and bowel function is relatively common. That's seen when there's spinal lesions above S2. So that's pretty low that can start happening. So odds are, in a lot of those cases, you're going to see issues with bladder and bowel function. That can be something that can be embarrassing for them, especially early on in the process. So that's something that we can help with, like what we talked about, being respectful to our patients and making them feel like a person, not like their disability. We can help them to feel better about themselves, even though they're having some things going on that they're not really so excited about. Another thing that's relatively common, and I'm sure you guys have heard of these before, pressure ulcers. You've probably heard of them as bed sores, if nothing else. This happens a lot to, patients that have had spinal cord injury because they have constant pressure on their body, on their weight bearing areas, basically all the time. You know, if you think about it, they're not ever up off of their rear. It's either on a chair or on their bed or things like that. That was why when I worked at the NMRC, one of my favorite things to do was to get our non-ambulatory clients, or our clients who they might not have had a spinal cord injury, but they were patients that couldn't get up and walk. And they, all day long, they were either sitting on something, laying on something, they had pressure on their bodies. So I could get them to the pool, which was 92 to 94 degrees. Warm water is what you want for this group. Put them in the water, have, I would put a life jacket on them, floats on their feet, and I could actually just kind of drag them around in the water slowly and let it. They loved it, loved it, loved it, because they had no pressure on their body at that time. It was the one time, 1 or 2 times a week when I had them in there and had them in the pool, that they didn't have that pressure on their body. So pressure ulcers come from when people have this pressure all the time and they're not turned often enough. They're very painful. So if someone has pressure ulcers, they're going to have a hard time, doing very much movement. Pool probably wouldn't feel too great to them if they already had a pressure ulcer either. Chlorine would probably burn it a touch. So just things to know that can happen with this particular group. The next one we'll talk about spina bifida. We talked about this group already. We know that it's the most common neural tube defect. It's where the spinal column doesn't completely close is what's going on here. So there's the different types, range from occulta down to myelomeningocele. And occulta is the mildest. You're not going to see any disability. We've talked about these before. Meningocele is where it protrudes from the spinal opening, but it can usually be fixed. Myelomeningocele is where there's paralysis, hydrocephalus a lot. The swollen head happens with myelomeningocele. This is the one that you can actually look at someone and see that they have spina bifida. The occulta, some of you I'm talking to right now probably have occulta and you don't know it. Some considerations during exercise. A lot of times these patients have a shunt, and that's basically, that drains fluid from hydrocephaly, because that fluid will just continue to build if it's not released. So need to get rid of that. So we need to avoid things that are going to cause trauma to the shunt. Scoliosis is common in spina bifida. That's just, curvature of the spinal column that's not normal. The normal spine does have some curve in it, but this is generally going to the side or is extreme. So we don't want to, further hurt someone who has scoliosis, because it's going to already cause them some physical limitations as far as flexibility, trunk movement, and all that they could do. And something else common with this group, which is strange to me, I don't really know why, but latex allergies. A lot of people who have spina bifida are actually allergic to latex. So, as providers, especially in this time of COVID, everybody's wearing gloves and masks and all of these things. We would have to know whether or not these patients had latex allergies, and not just for spina bifida patients. There's others as well, but it's just kind of a common thing with this group, where we wouldn't be handling them with latex gloves and setting, next thing we're having to do is give them an EpiPen to keep them from going into, shock from us handling them with latex gloves. So just some things to know. And that again plays back to why it's important for us to have communication with the other departments and know things like this, that they are allergic to latex. That's something that as a recreation therapist, you probably wouldn't have on your assessment list of things that you're going to find out. That doesn't tell us what their strengths and weaknesses and interests and things are. You would find that out from the nursing department, the intake paperwork, the doctors, things like that. Those individuals are going to know this and share this with the group. We also work with people who have amputations, and this is most common in people who are over the age of 65. Common in patients with diabetes. And we all know what an amputation is. It's the removal or absence of an extremity due to disease or injury. Or because of, sometimes there's just differences in the limbs due to birth defects, issues during childbirth. They could just sometimes their limbs can just be malformed. Amputations are harder on a lot of our patients mentally because they know what it's like to have that limb before in a fully functional role. So you fight depression with this group, and you also deal with phantom pain, which is coming up next, actually. This is usually temporary, and it's basically they feel pain where that limb used to be. Even though they can look down and see that there's nothing, say, below the knee on that leg, they feel pain in their lower leg. Their brain still is telling them that their lower leg hurts, even though they know by looking with their eyes that their lower leg is gone. Phantom pain is very strange. It usually goes away with time. So when we're talking about exercise with this group, we can work on things like movement and balance. They're going to have some difficulty with that. So we can help them to improve on that through doing specific activities that can help them to work on improving their movement, making it more efficient, making their balance better. There's really, really cool prosthetic devices out now. I mean, you've all seen the runners in, Paralympic games that are running on these blades that look like, I don't know, it looks like you should be able to run faster with these things than you could without them. Not saying that I would want to cut my legs off and use those to try to get in the Olympics, but I'm saying they're pretty darn cool looking prosthetics. And they've also gotten really good with prosthetics as far as making them look a whole lot more realistic, which is a plus. People don't want to stand out, just for that reason a lot of times. So that's a positive. So there's prosthetics that are specifically used for physical activity, prosthetics for the arms that allow them to grip things, prosthetics for the lower body that help them to run and do things like that. If it was, say they wanted to bike, there are ways that you can clip, your bike to the lower limb and make it where it would not come off. They can't use their toes like we would to hold theirself on the pedals. We also have to watch for skin care and pressure sores with this population as well. If you think about cutting your leg off at the knee and then putting all your weight on something that's going to be moving on it all day, eventually it seems like that until that skin is toughened up and used to it, especially, pressure sores can be a real problem. Blisters and pressure sores are relatively easy to get for this population. So we got to watch out for that. Stroke, patients who've had strokes, that's another group that we can work with. Stroke is the third leading cause of death in the US. It's also known as a cerebrovascular accident or a brain attack. I've never called it a brain attack, but apparently some folks do. The location of the stroke and the severity of the stroke are going to determine the function loss. So where the brain is affected, and you know what's happening in a stroke is blood loss, is blood flow is cut off to a specific area of the brain. When that portion of the brain doesn't get blood for long enough, there's damage. So that's what's going on in a stroke. You know, much as a heart attack, you know, you have a blockage where oxygen isn't getting to that area. This is just the same thing going on, but with the brain. So when someone's had a stroke, they need to have an examination by a physician to check their heart. At this point, to check their circulation, not just their heart, to make sure that they're safe to resume exercise at this point. And that's what you want, you know, make sure that they have a clear checkup. And if they've had a stroke, they're going to be under physician care for sure. So something else common, a lot of times this is tied right in with stroke, is hypertension, high blood pressure. Because a stroke affects generally one side of the body, you know, that's why you see a droop in one half of the face, inability to use one arm or hand as well as the other side. You know, a lot of these things can resolve through time. A lot of these things we could help them to get better through time by working on, you know, fine motor skills and things. But because it affects one side, balance is going to be affected. So their balance is affected while sitting and standing, because if you don't have use of half of your body, I mean, that side's just going to want to basically slump, you know, so the other side is going to try to overcompensate to the point that your balance is just thrown off. Another thing to think of when we're not just on the exercise side of things, but when we're working with people who've had a stroke, they're going to have difficulty with speech and language. You know, a lot of times that's one of the first signs of a stroke, is you start having trouble understanding them when they're trying to talk to you. They don't have control of, you know, half of their mouth, and it makes them have a hard time talking. So we have to make sure that we give them time to tell us what they need to tell us when we're trying to work with these particular patients. Okay, acquired brain injury. There's 1.9 million of these a year. You know, we're basically talking about TBI, traumatic brain injuries, and closed or open head injuries, which we've talked about. There's a variety of causes, from football players getting concussions all the time, probably the most common. Car accidents, gunshots, a tree limb falling out and landing on your head. Gosh, there was a little boy in, I think, Tupelo in the last few years that was, they had a storm there and everybody was going back to their car, and a limb fell on him and he died from a limb falling out of a tree on the way back to the car. So, I mean, you never know what can cause these brain injuries. Depending on, again, where the injury is, how deep penetrating it may be, or how hard of a lick you get to the head, your signs and symptoms are going to range from mild to severe, depending on all these things. And we talked about how there's multiple impacts on the way these individuals are going to function and the way they're going to behave. When we're talking about exercise for people who have brain injury, we're going to be looking for things that are similar to those who have had a stroke, because a lot of times they have damage. You know, when there's damage to the brain, there is a disconnect between what your head is telling your body to do and what your bodies will actually do, you know. And they may have a lot of things where they are, you know, they have one side affected more than the other, because if depending on where the injury is, that's going to determine where their symptoms show up. We have a little bit less predictable consequences for people with brain injury, because there is such variety and such uniqueness to each injury, that it makes a predicted outcome a little harder to do with this group, because every one of them is going to be so different from one another. There is an increased possibility of seizure in this population. Most of them will be on medications. Again, we need to know what sort of side effects their medications cause. Does it make them super sensitive to the sun? Will it make them get dehydrated? Is it a diuretic of some sort? Is it going to make them have to pee every 10 minutes? We need to know things like that if we're going to be trying to work with them. Multiple sclerosis. We've talked about this group as well. 400,000 Americans have multiple sclerosis, and it's predominantly seen in women. It's an autoimmune disease that affects the central nervous system. And again, what this is all about, multiple sclerosis, is demyelination of the, when our body is sending impulses, it goes down, axons, and they meet and information is transferred. And the myelin sheath is what serves as insulation when this information is being passed. When this myelin is taken off, then all of the information that is trying to get where it needs to go to tell our body to move a certain way or do a certain thing starts to be less effective, because the insulation is gone and some of the information is lost, basically. That's a roundabout way to put it, but it's pretty accurate to what's actually going on. 4 types of MS. About 85% of the cases are relapsing remitting type. 10% are primary progressive, and the remaining 2 would make up the other 5% total: secondary progressive and progressive relapsing. Relapsing remitting is where we talked about how they will have times where they'll have basically no symptoms at all, and then it'll relapse and they'll go into another stage of dealing with the symptoms of MS, such as fatigue and heat intolerance and balance issues, things like that. Comes and goes in relapsing remitting. That's the most common. Then there's primary progressive, where it is basically just a progressive worsening. You start to have cardiovascular dysautonomia. Sorry, that was a long word and hard for me to say today, apparently. Low heart rate, low blood pressure is basically what that is. That's just something that comes along with this primary progressive type. Some things when we're talking about exercise for this group, we just talked about how blood pressure and heart rate are affected a lot of times. Low heart rate, low blood pressure. What I can tell you how that would make you feel: like a sloth, like a slug. If your blood pressure is super low and your heart rate is super low, you would be tired from walking to the kitchen. Like that's not how our body needs to be to have energy to exercise. So that's something that we need to realize may be a real issue. Fatigue is also very common, especially when we're during a relapse phase. That's very common in this group. When they're fatigued, you obviously have to be more careful for falls. You have to be more motivating. to try to get them to want to participate if they're already tired. Heat intolerance is common with this group. They get overheated kind of easy. When they overheat and overdo it, then a lot of times their symptoms end up being worse. So we try not to get them overworked and overheated also. So that's something to think about with exercise for them. Again, we need to know about their medications and what side effects they may have. Something else we see is optic neuritis, which is basically just blurring or loss of vision for these guys. That's obviously a problem, when we're talking about exercise, especially if we're trying, don't have them in a safe space. So we need to make sure that they're in a place where they're not going to be tripping over things that are in the floor, or stepping off a step that they don't see is there. So balance is an issue, pretty common with this group. That's going to increase the risk of falls also, so we need to watch for that. And then muscles start to weaken starting in the lower extremities. It's just kind of how this disease works. You start seeing the loss of function in the lower extremities first, and then it works upward. So by the time someone, it has moved up and gotten into the upper extremities, they're generally either in a very strong relapse, or if they're the progressive type, they're getting pretty far along their process when they've gotten to the upper body. Muscular dystrophy. This is hereditary disease. 80% of those that are affected are men. It's odd to me. I don't know why. It's and researchers don't even really know why on most of these cases. How 80% of these are men. Why? Why is 80% of why are most of the multiple sclerosis cases female? I don't know. It's just some little trigger that causes that. But muscular dystrophy is progressive muscle degeneration. The earlier the symptoms show up, the faster the disease usually progresses. We've talked about this. This is a good chapter because it's kind of review in a lot of ways, but we haven't talked about really the exercise part per se. The three most common types of muscular dystrophy are Duchenne. That's the main one that we talked about. Facioscapulohumeral and limb girdle. Those are the three main most common types. Duchenne, again, is the main one that I will have you talk about because it's so much more common than the others. You're going to see things like muscle tightness, involuntary movements, movements that they're not even trying to do, problems with ambulation or walking, balance and coordination impairments. These are the things that you'll start to see in this disease, and it will, progress. This is a progressive disease that we really can't stop. We can just, through therapeutic recreation and through exercise, as it says here on the slide, we can slow the progression of some parts of the disease. So that's our goal. We can help to limit contractures, which is what we're talking about when we say spasticity. Contractures, we're talking about contracting muscles that don't release, same thing as spasticity. Those are the same thing. Super tight muscles that you've probably seen people in wheelchairs that are drawn up real tight. They are dealing with contractures and spasticity. And my best way to work with this group, as I told you before, was aquatic therapy in a warm water environment. Really helped to relax some of that out. Respiratory problems are a big problem with this group as well. So we probably wouldn't want to push them too hard on a lot of exercises for that reason. If they already have respiratory problems, we don't want to put them into respiratory distress through something that we are doing. And through the progression of this disease, respiratory problems a lot of times will be what ends up getting them in the end, basically. Cerebral palsy, another group. It's non-progressive. It's due to brain damage. Things that are affected are muscle control and coordination. 90% of the cases show up before or during birth. 10%, the remaining 10% are going to show up before age 3. So by age 3, you should know whether someone is going to deal with cerebral palsy. And they have a lot of different conditions that affect the function of their, muscular control and of their coordination. There's 4 different types that are listed here. Spastic with some muscle tone, 70 to 80% of the cases are spastic. Then there's athetoid with uncontrolled flailing movements. Athetoid is basically just the opposite of the spastic. Spastic muscles are very tight. Athetoid, floppy, uncontrolled. Let's see. Ataxia, where you're going to have balance and coordination problems, 10%. And then there can be a mixture of all of the above. So when you're dealing with spasticity, obviously have trouble with movements. Ambulation is going to be, or the ability to walk is going to be affected. Balance is going to be affected also, and general coordination. This is the one we were talking about where they may be, if you're reaching for a cup, a lot of times they'll overreach and knock a cup over. Not because they want to, just because they can't control their movements that well. So we can try to work on things like fine motor skills, like grabbing a cup, through doing activities with them where they have to concentrate on, precision type movements. We can work on things like balance with them that can improve their quality of life, coordination. Some people with cerebral palsy can walk to a certain degree. We would have to, we could work with them on ambulation. A great place to work with them again would be in an aquatic environment because it takes a lot of weight off of them. It would help them to keep balance. They would need a little less assistance from us in a water environment, although we'd have to be right there with them. People with intellectual disabilities, we've discussed them. It's the most common developmental disability in the US, and there's a variety of causes and a variety of different types of intellectual disability that we've talked about. When we're talking about exercise and teaching them what they need to do, how they need to do it, we need to remember that a lot of times they have impairment in their memory. So we may have to teach somebody how to do something more than once who has an intellectual disability. That plays into the whole patience thing we've talked about. They may not be trying to be a butthole. They may just need us to tell them how to do it again. We got to remember that. It takes them longer to process information than it would most of you in this course. So that's something to think of as well. Give them time to think. Give them more chances to learn what you're trying to help them actually do. Repetition is key for this group, for them to learn how to do things. Repetition is where it's at. A lot of times for them to start being able to do repetition, you have to show them how to do things first. A lot of times this group also responds very well to rewards. And, this shaping and chaining are talking about getting them progressively closer to doing exercises and activities in the proper form. You're getting pieces put together until they're doing things the right way. Appropriate pace of speech. One thing, this reminds me, and this is something you see a lot when people are dealing with people with intellectual disabilities. The first time they meet them, they may have a hard time, putting together a sentence or figuring out what they want to say or how they want to say it. So they may speak very slowly. We do not need to speak very slowly back to them. That's demeaning, kind of along the lines of what we've talked about before. We also, by conversating with these individuals and having interactions with them, we can help them to kind of train themselves to find that appropriate pace of speech for normal interactions. A lot of people who have intellectual disabilities have congenital heart problems where they have a lower max heart rate. They have low muscle tone a lot of times, and something called atlantoaxial instability. This is common in Down syndrome for sure. It's found in the cervical spine. It makes them prone to damage in the cervical spine. So probably don't want to do activity. They're not allowed to dive in Special Olympics. Individuals with Down syndrome are not allowed to dive into the pool when starting a race because of this instability that's talked about here. Just an interesting fact. Even though they shouldn't hit the bottom, they're still super careful about protecting that cervical spine. Autism, another group we deal with. It's a spectrum of conditions. It appears to be inheritable. There's a lot of discussion and question about exactly what causes autism. I know autism is a heck of a lot more prevalent today than it was when I was a kid. You hardly heard of autism when I was a kid. Now everybody's getting autism. I think part of it is what we're getting exposed to these days. I think part of it is that the detection is a lot better now than it was, and they're able to identify people who have this a lot better than they were in the past. It's a pervasive developmental disorder. That's just how it is classified. It's evident by the age of 3. And we talked about the characteristics of people with autism. They have social impairment, number one. That's probably the main thing that comes to mind. They're going to play by themselves instead of with others. They do self-stimulating behaviors. They have difficulties with communication or just don't want to communicate. They have, they have different sensory needs than you and I may have. A lot of them love, one of the favorite activities for the patients who had autism at NMRC, they love to swing. Try getting them off a swing when they're on there. That's a tough task. They love to swing. That is something that stimulates their senses that they love to do. A lot of the clients I would see when I was working in the pool, they love to go underwater. The autistic clients, they would go underwater and just listen to the sounds and things underwater. You could tell that was a sensory thing that they liked a lot too. A lot of things that have a squeezing effect is something that they like. Loud noises are a no-no. Could totally set off an inappropriate reaction for sure. Crowds are not something that they particularly relish either. And they can be overstimulated. If they're in a group, that plays into why crowds aren't the best thing a lot of times. They get overstimulated. If they hear 20 people talking from different directions, it's just going to be too much. So in that way, I think I might be a little autistic myself because I can get that way myself too. I'm not a real big, large crowd person either. When I get home in the afternoon and my 3 kids are trying to talk to me all at one time, I start having some of these symptoms myself. So when we're talking about exercising with this group, we have to realize that they have a significant social impairment. So we can't expect them to, be out walking with the group and conversating the whole time like that. We can't ask them to talk as much as other people. Now, just being around the group and walking with the group is socialization for them, and that's a positive. We talked about how they have issues with sensory integration. We may need to modify their environment sometimes. I talked about how there was a client that I used to work with that would get totally entranced by a ticking wall clock. If I wanted his attention, I had to get the clock put away where he couldn't hear the clock and couldn't see the second hand going. So sometimes we have to modify the environment and get rid of distractions and things that are going to bother them. Sometimes you see gross and fine motor skill impairment, communication impairment, low muscle tone, seizures are seen a lot of times in this group, and then difficult behavior that a lot of times we can't really even explain because they're not communicating to us what is upsetting them. So they may have an inappropriate outburst that we have no idea what it's about. And it may be because we were supposed to leave for lunch at 12 o'clock and it's 12:05 and they are really ticked because it's 12:05. But they don't really want to talk to us. So instead of talking to us, they may throw their desk. I don't know. I'm just saying it's interesting with this group because of the lack of social interaction and skills with a lot of these individuals. We don't really know why we see the difficult behavior that we see. Prader-Willi syndrome. I haven't talked about this group yet, I don't believe. It is another group that we worked with at NMRC. They have their own little group home. It's a genetic disorder that's not inherited. Usually comes along with intellectual impairment. There's physical characteristics that are there. One are they kind of have specific facial features that if you see a group of them, you'll all look kind of the same. And the second one is they have an insatiable drive for food. So I think that I don't really have the facial features portion of it, but I do have the drive for food. So I might be half Prader-Willi. I'm not sure. But what it is they will eat. If they have food available to them, this population, they will eat basically until their stomach blows up. They do not have anything that tells them, hey, I'm full, I've had enough. It's just, I want more food. I want more food. They have such an urge to eat that they will steal food. They will sneak food. They will hide food in their rooms. So when we're working with them, taking them on trips, doing things like that, we have to monitor their food supplies. At the regional center, when they would come in, generally this group, they would be, I don't know, probably 5'2" on average, and probably 300 and something pounds when they got to us. And they would go on a strict diet immediately, which would make them very fun to be around because they really like that, just like you and I would, being on a very strict diet. So their mood wasn't the best, but they, within a year, you cannot even recognize these clients. They look so different and they've lost so much weight and they've gotten so much healthier, and they're walking, they come over to the recreation building. And this is one situation where they get a specific exercise plan that they do on a regular basis. They come 5 days a week, walk on the treadmills, and do a certain amount of miles per week to go along with a very specific plan for their dietary needs. They're on like 1,200 calorie meal plans that are strict. So that's another situation where we as recreation therapists have to work with the dietary nutrition group to keep them on that, on the plan. We don't want to be sabotaging healthy weight loss for this group. But the main thing about Prader-Willi to remember is that it is a very much a eating disorder where they will just eat. That's all they want to do is eat. And it must be a miserable state of being. If you think about it, you feel hungry all the time, whether you are or not. That would be very frustrating to me. They also, they have short-term auditory memory of things that we tell them. They may forget things that we actually verbalize to them. Their attention spans are short. They don't really have a lot of abstract thinking. They take things very literally. I've seen all of this bottom on this one firsthand: stubbornness, opposition, manipulation, rigidness, depression. They are very strong-willed, strong-minded individuals that all act just alike and they look just alike, and they are the most manipulative little guys that I've ever worked with in my life. They're also pretty high functioning. They can all talk. They can all be very manipulative. They're an interesting group to work with. So if any of y'all ever come out to NMRC, I want y'all to notice, to try to make it a point to be around some of the Prader-Willi clients a little bit and work with them, because they are an interesting group, to say the least. All right, we made it. That was a long day, guys. Thank you for hanging in there. That took us 2 classes to get through that. I will give you guys an update through Blackboard about what we're going to do next class, but we're doing very well as far as what I wanted to cover this semester. I've been in a rush to try to get through everything that I wanted to get to, but we're at this point, we are ahead of the game. So I'll give y'all an update between now and next class. You guys have a great weekend. Anybody have any questions or anything before we go? All right. Good to see y'all. Y'all have a good weekend. Be careful. Later, guys.
Bye. Thank you.
You bet.
Mr. Rasher.
Yes.
Yeah, okay, so is our other paper going to be up for us to reference off to write the other one? The reference
The what now?
paper?
Your signal's cutting out.
Oh, I'm sorry.
Okay,
Can you
now
hear me?
I can hear you. Now I can hear you.
Okay, is our first paper going to be up for we can reference off of it?
Hey,
The other one.
hey, let me cut you off. Send me an email asking me the
It's still
question.
cutting out.
You sound clear as a bell, and then you get to the same point in your question and it goes bye-bye. So I don't know what's going on. Send
Yes,
me
sir.
an email and I'll answer you, okay? And if it's something I need to share with the whole class, I'll send out an announcement about that too.
Yes, sir.
All right. Thank you.
Thank you.
All right. Have a good one.
Mr. Brasher,
Yes, sir.
I was gonna just ask you a question. Do you remember I reached out to you earlier this year about any internship possibilities you might have?
Mm-hmm.
I was just wondering if you knew if you ever heard if any of those are gonna actually do internships or not yet.
NMRC is starting to have them again, which is one that's close. Oxford Park Commission takes interns. Those are both good options, and I know that they're both actively taking them.
Okay. All right.
So that's a start. That's a start for sure, and they're both close.
You said NMRC, and what was the other one? I'm just gonna write them down.
The Oxford Park Commission.
Okay.
I mean, they can both be semi-competitive, so you want to kind of jump on it. But the first thing that I have before you really get super duper far in the process is talk to Bradley and get him to let me know that you're clear to do an internship. You know, once he tells me that, you can try to nail one down. Then you've got to show me that you have your CPR certification. And from there, we kind of just close it up. There's the competency exam that happens toward the end of this semester. I don't remember the date off the top of my head, but you probably need to be taking that also.
Okay.
You have to do
Uh,
that prior to being actually enrolled, but you can be lining up an internship,
Right.
now.
Absolutely.
So I would check at the North Mississippi Regional Center. I would check with the Park Commission. Seth Gaines is the director there.
At the park.
Park Commission, yes.
Okay.
SETHGAINES.
Yes. Okay.
Okay.
All right. Awesome. I have a meeting with Bradley on Wednesday. So
Okay. Perfect.
I'll
Good
probably,
timing. Just tell him, ask him about the internship, and he's just gonna say, you need to talk to Brasher about your intern. Yes, you do, but I need to have something from him saying that you're good to go on the academic end.
okay.
You know,
Alrighty. Yep.
before that, I can't really even like say, yeah, that place will work,
Right. Right.
So
Absolutely. Well, I appreciate it. Thank you.
perfect. You bet. You have a good one.
You as well.
All right. See ya.